Probably 90% of patients can be imaged from the apical window. It's a very important window, and it's the second window we use after we perform the parasternal long axis. Where is the window located? It's located at the apex, which can be very variable. Usually it's somewhere in the region of the fifth intercostal space, but it can be located further up or sometimes even further down, and the apex can also be rotated more towards the back or even more towards the sternum. So there's a high variation, and you will have to just play around with the transducer until you find where the apex is. Special problems we have is in very slim patients where the apical window is sometimes not visible at all or not present at all, simply because the axis of the heart is so steep that the whole heart is hidden behind the sternum. Another problem is patients who have COPD, where we have lung tissue which obscures the apical window.
One of the most frequent mistakes that people make when they look for the apical window is that they put the transducer much too medial. It's important to really position the transducer laterally but also apically. I will show you what I mean by this. This is a much too medial transducer position. If I move the transducer laterally and also apically, then I have a perfect orientation of the septum, and I have the avoidance of foreshortening.
There are several different views we can get from the apical window. Some views we will get by rotating the transducer, and others we will get by tilting the transducer. We'll first talk about the probably most important view, the four-chamber view.
The four-chamber view is probably one of the most important views in echocardiography. First of all, it's a view where we see very many structures, and then it's also a view from which we can find all the other structures more easily. So I'll show you how to orient the view, and then also which details you can depict. The four-chamber view should be oriented in such a way that the septum is parallel to the ultrasonic beam. It is furthermore important to really check that the atria are as large as possible, because if you're down like this, then you don't have an optimal four-chamber view. So you have to tilt until you really get large atria. And if you do so, you can see the following structures. We have the lateral wall of the left ventricle, we have the septum, we have the right ventricle with a moderator band, we have the lateral wall of the right ventricle, then we have the left atrium, the right atrium, the interatrial septum with the fossa ovalis, we have the tricuspid valve with the septal leaflet, and here the mitral valve with the anterior leaflet, the posterior leaflet. If we want to go into more details, we can even see the pulmonic valves as they enter the left atrium. This is the right upper pulmonic vein, not valve, of course. The right pulmonic vein. Those are the left pulmonic veins, the lower and the upper. And here you would see the descending aorta, the orthogonally orthogonally visualized descending aorta.
So in summary, the four-chamber view shows you four chambers: left ventricle, left atrium, right atrium. It has the shape of a bullet. The left ventricular wall is thicker than the right ventricular wall. And we also see the mitral and the tricuspid valve. The plane is oriented in such a way that we transect the left ventricle with the apex here and the atria further down also in the image. We use the four-chamber view to assess global left ventricular function and regional left ventricular function. We'll be talking about that in more detail when we talk about coronary artery disease. The function of the valves can also be seen very nicely, of the mitral valve and the tricuspid valve. So it's a very important view where we have an oversight of many structures of the heart.
It is also possible to visualize the pulmonic veins. You can do that best from a four-chamber view, and the easiest pulmonic vein that you can see is the right upper pulmonic vein, which is located here. I can demonstrate that by putting the color in here, and you can see the flow into the left atrium. You would have the left pulmonic vein here. This is the lower left pulmonic vein, and the right pulmonic vein here. Again, I'll try to put the color in to demonstrate that. Yeah. You can nicely see the flow of the left upper pulmonic vein into the left atrium. What you cannot see here is the right lower pulmonic vein. But what you do see is you see the descending aorta. This is the structure you see here. And you also see at least the entrance of the left atrial appendage, which should go towards the anterolateral wall of the left ventricle.
So you saw that there's more to see than the four chambers in the four-chamber view. And the pulmonic valves do have a lot of importance, especially if you want to assess flow and diastolic function. We'll be talking about that in the chapter on diastolic dysfunction. But in summary, we have the left pulmonic veins entering the heart here on the left, with the left lower pulmonic vein and the left upper pulmonic vein visible. And then we have the right upper pulmonic vein, which is the vein we use for flow assessment. The right lower pulmonic vein is usually not visible, and this is a vein we just simply do not see. One problem that we have when we perform a four-chamber view is that of foreshortening. Foreshortening is a problem we get if we do not transect the left ventricle really at the apex, our transducer position just too far cranially, and thereby we do not see the true apical structures. Let's take a look at that.
So how do I recognize that there is foreshortening? Well, the most important finding is that you have a rounded apical shape. You see, the apex is not pointed but round. The second finding is that you have a rather short left ventricle, especially when compared to the atrium. How can you correct this? You can correct it by just moving more apically and laterally. Okay, this would probably be a better view. So this is much less foreshortening. Of course, you cannot avoid that you miss some of the supraapical views, but this is certainly better than what you've seen before. If you really need to see the supraapical views, there's another trick that you can use, and that is by bringing the patient more in a position on the back and rotating the transducer very, very laterally, and then all of a sudden you will get views which are very atypical, but which do show you regions of the apex that you cannot see with even the optimized four-chamber view.
Again, just for comparison purposes, the same patient, once we imaged him too far cranially, we have foreshortening. We see that the left ventricle is very short. And then we image the patient from the right position where we do not have foreshortening, much longer left ventricle. The ventricle at the apex also has a different shape. So this is the view you should try to achieve and not this view. The problem with foreshortening is that we underestimate volumes. We do not see problems located at the supraapical regions, for example, an apical thrombus, and also we do not see supraapical infarcts. To avoid foreshortening, very important, try to use a very lateral transducer position, and the orientation of the transducer position should also be more caudally. And if you cannot avoid foreshortening, try rotating into the two-chamber view, which we'll be discussing later, where we have much less problems of seeing the true apical structures. Very important, if we perform echocardiography in general, always feel free to move the transducer out of the standard views because sometimes you will have to do so to really optimize to what you want to see. So I will show you some variations of the four-chamber view which are helpful in certain situations. One of these views is the four-chamber view where we have the septum oriented in such a way that it points more towards the right and that we have a more perpendicular beam orientation to the septum. This view is very helpful to detect, for example, atrial septal defects and also to look at wall motion abnormalities here in the lateral region. It also points to a fairly medial transducer position. The second view we can use is the so-called lateral transducer position where we optimize the four-chamber view for the right ventricle. Thereby the septum points more to the left and we again have a very perpendicular beam orientation to the septum, and we have a very good view at the right ventricular structure. So this view, even though it's not a classic four-chamber view, is sometimes often important or very helpful in assessing right ventricular function. Let's take a look.
The orientation of the interventricular septum is very important. Normally, it should be oriented in such a way that it is parallel to the ultrasound beam. If your septum looks like this, slanted, then you know that you are much too medial with the transducer position. But all you have to do is move the transducer more lateral, and there you are. On the other hand, if the septum is oriented in this direction, then you're too lateral, and you have to move back. In the four-chamber view, it's easy to see the right ventricle. However, very often, the quality of the images is not as good as you would like them to be, especially for the right ventricle. There are ways of optimizing this view, and this is by simply moving the transducer more laterally and pointing the transducer more towards the right side of the body, and thereby you have a more perpendicular orientation of the ultrasound beams to the lateral wall, and you have a much better delineation of the endocardium. So this is the view that you can use if you really want to look at the right ventricle and to assess function, size, and further other things.
So again, in summary, we have the different views with the classic four-chamber view here in the middle with the correct position or the normal position of the transducer at the apex. Septum is oriented parallel to the ultrasound beam. Then we have a more lateral transducer position where we optimize for the right ventricle in particular. You see we have the transducer more on the lateral side. And then we have the more medial transducer position where the septum is now pointing to the right. Very good for imaging problems here located in the atrial septum, for example, atrial septal defects. A few examples. Medial transducer position. Very nice view of the right ventricle. Septum is pointing to the right. Normal four-chamber view. Vice versa, very lateral transducer position. Left ventricle, right ventricle. Septum points to the left. Very good delineation of the right ventricular structures. For comparison purposes here on the right again, the classic four-chamber view. So let's see what happens if we tilt the transducer. If we tilt the transducer from a classic four-chamber view here in blue, upwards we transect different structures of the heart, and thereby we get the so-called five-chamber view.
You come to the five-chamber view from the four-chamber view by simply tilting the transducer and getting more shallow towards the ventral portion of the chest. So this motion brings you to the five-chamber view. What do you see in the five-chamber view? You see the LVOT and the aortic valve. You don't see the mitral valve as well anymore, simply because you're now cutting in the ring of the mitral valve, and you're kind of more in the commissural, anterolateral commissural region of the mitral valve, so you can not really distinguish between the anterior and the posterior leaflet in all cases. So it's this is not a view where we traditionally look at the mitral valve. The left atrium is not in its maximal dimension, so also know a view where you would really look at the left atrium. The walls, this is the lateral wall, this is the septum, but here you would be more in the anterior portion of the septum and not in the inferior portion of the septum. What is this view good for? Well, basically it's good for looking at LVOT problems and aortic problems, assessing problems such as stenosis or LVOT obstruction and aortic regurgitation, of course. One little trick that I would like to show you is if you move the transducer even more lateral, you will get a better perpendicular orientation to the LVOT. This can sometimes be of benefit.
So for summary purposes, 5-chamber view, where the 5th chamber is the left ventricular outflow tract in the aorta, and portions of the left atrium, right ventricle, and left ventricle are visible. This is such a 5-chamber view with the aorta and the left ventricular outflow tract here. We see that not the entire left ventricle is visible, but only the cranial portions. Thereby we have the impression that the left ventricle is small. This view can be used especially good for problems of the LVOT, for assessing problems of obstruction here, and also to measure, for example, the degree of aortic stenosis with the help of Doppler. But we also have a way of looking at the anterior portions of the anterior septum here, because we here are tilting towards the anterior of the heart. From the 4-chamber view, if we tilt the transducer not towards the 5-chamber view cranially but more caudally, we get different structures within the view of the heart.
The coronary sinus view is a very important view. It's actually a reversed 5-chamber view. Why? Well, basically what we do is we start out from a 4-chamber view, and instead of going ventrally with the transducer, tilting the transducer and getting the 5-chamber view, we do just the opposite. We go deeper into the heart, going posteriorly or to a region where all of a sudden we see the coronary sinus. The coronary sinus is this structure right here. The coronary sinus is located between the left the ventricles and the atria, and this is where it enters the right atrium. Why is this view important? First of all, because we can look at the inferior portions of the septum, and the second reason is because we can see the commissural region of the mitral valve. Of course, we can also look at pathologies in the region of the coronary sinus.
The coronary sinus view is a very important view. Even though we do not see the left ventricle or the entire left ventricle, only the basal portions of the left ventricle, we have a way of looking at the basal septum and to assess regional wall motion abnormalities here. Furthermore, we only see the basal portions of the right ventricle, but we do see the coronary sinus, and thereby we can look at pathologies which are located or which affect the coronary sinus. This is an example of a still frame of such a coronary sinus view. The coronary sinus is visible here. Those are the basal portions of the right ventricle with the trabeculations visible, and this is the basal inferior septum. What pathologies can be studied? For example, persistent vena cava superior, very nicely visible here, the dilated coronary sinus and the contrast which enters the right atrium. We'll be talking about that pathology later when we talk about congenital disease. Dilated coronary sinus are also seen, for example, in the presence of elevated right atrial pressure, and in cases where patients have a pacemaker lead in CRT patients, we can also see those leads within the coronary sinus. So the coronary sinus does have an importance in various clinical situations, and with this view we can visualize the coronary sinus. Now, what happens if we rotate the transducer from the 4-chamber view? This is the 4-chamber view again, and let's see which views we get. First, let's look at the 2-chamber view.
The easiest way to get to a 2-chamber view is when you start out from a 4-chamber view. So this would be the 4-chamber view. But before you rotate, before you try to get there, the most important thing is that you have to try to get the ventricle right in the middle. Because when we rotate, we will be rotating around that middle. And if you do not put the left ventricle in the middle, you will be rotating around different structures and not the left ventricle. So now we have the ventricle in the middle, and now I will be rotating without changing the axis slowly counterclockwise, and you will see that the right ventricle gets smaller and smaller, and at the same time you will have to try to assure that the size of the left atrium remains as large as possible. If you lose the size, you will also tilt out of your axis and you will not get a decent two-chamber view. So this is basically just to give you an aid that you're still on track. So you rotate more and more until you finally arise at the two-chamber view where you do not see right ventricular structures. In the two-chamber view, what you will be seeing here is the anterior wall, the inferior wall, the left atrium, and the mitral valve, where you cannot distinguish between anterior and posterior leaflet, simply because you're now exactly parallel to the closure, to the commissural closure line.
In summary, the two-chamber view shows you two chambers, the left ventricle and the left atrium, with the anterior portions of the left ventricle seen on the right of the screen and the inferior portions seen on the left of the screen. The mitral valve is also visible, but we cannot delineate between the anterior and the posterior leaflet simply because we are transecting the two-chamber view or the mitral valve right at the line of closure or in the region of between the commissures. So the advantage of the two-chamber view is that we do not have such a big problem with foreshortening because we're now rotating into the apex, and thereby we do not have the problem that we're missing much of the apical portions. However, we do not see the right ventricle. What is the two-chamber view good for? For global function together with the other views, for regional wall motion abnormalities of segments which are seen in the two-chamber view, the mitral valve to detect, for example, the origin of regurgitation, and also to help in the assessment of the severity of mitral regurgitation. It's sometimes very difficult to get a good two-chamber view, and there are a few tricks that you can use to help to optimize your two-chamber view.
Sometimes the patient have better image quality if they inhale. This is especially true for the two-chamber view, and I'll try to demonstrate that here. This is a patient who has moderate quality of the two-chamber view, and I will now ask the patient to inhale. Können Sie mal einatmen? See, and immediately we get, das ist zu viel, ein bisschen ausatmen. We get better image quality. Sometimes he should not excessively inhale, as in this case, but if he inhales moderately, you can see the anterior and the posterior wall much, much better.
From the two-chamber view, if we counter-rotate the transducer further approximately 60 degrees, we will get another view. And this view is called the three-chamber view, or also the apical long axis view.
Now I'll show you how to get from the two-chamber view to the three-chamber view. So let's start out with the two-chamber view. All you have to do is you have to rotate counterclockwise even further. The difficulty here is that you will have to switch your grip, basically, of the transducer very often. And to assure that you stay on axis, I always use my little finger to just assure that you're still in the same position. So when you rotate from the two-chamber to the apical long axis view, you have to rotate until you finally see the LVOT and the aortic valve. Once you see those structures, you're there. What can you appreciate? First, you appreciate the septum, the anterior septum. You have the posterolateral wall, the left atrium, and you have the posterior mitral valve leaflet and the anterior mitral valve leaflet. The difficulty of the two-chamber view opposed to the three-chamber view is that in the two-chamber view you are perpendicular to the intercostal space usually, while with the apical long axis view you're again oriented more parallel to the intercostal space, and so you have a better contact of the transducer with the body. So actually the quality of the images in the apical long axis view, at least in my experience, are better than those in the two-chamber view.
The three-chamber view shows you the left ventricle, the left atrium, and the aorta and LVOT as the third chamber. We have a potential to look at the aortic valve and also the mitral valve. So both valves are seen at once. Portions of the right ventricle are also seen, but this is not the view where you would assess right ventricular function or problems located in the right ventricle. We're located in such a way that it's a long axis view which transects the aorta and the left ventricle and parts of the right ventricle. The three-chamber view is good to assess global and regional wall motion abnormalities, the aortic valve, the LVOT for LVOT obstruction, for looking at aortic regurgitation, and also to look at the mitral valve with respect to the presence and mechanism of mitral regurgitation and mitral stenosis. This is a comparison that shows you the difference between the long axis views from a parasternal approach and from an apical approach. Basically, we see the same structures. We have the mitral valve here, the aortic valve here, the left ventricle here and here. The only difference is that we have the apex visible in the apical long axis view, and we do not have the apex visible in the parasternal long axis view. In contrast, the parasternal long axis view gives you a better image quality usually of the aortic valve and also of the mitral valve, because we're simply closer to these valves than we are from the apical approach. But the cut line or the cut angle or cut plane is the same between the long axis view and the parasternal long axis view. So those are the views we've seen so far on a schematic of the short axis view. The four-chamber view transects the left ventricle and the right ventricle, left and right ventricle. The two-chamber view transects only the left ventricle, and the three-chamber view transects the left ventricle and only portions of the right ventricle. This axis should actually be a bit more in this orientation, so we do have a bit more of the right ventricle visible. But sometimes there's a problem of really seeing the true lateral regions of the heart. And I'll show you a view which is very important and which can help you in many clinical situations.
So how do we get to this atypical view? Again, we start from a four-chamber view. This is the four-chamber view. And instead of rotating counterclockwise as you would to get to the two-chamber view, you would now rotate clockwise slowly until all of a sudden you see the aorta in here again. Now this is not the same as a five-chamber view because you're just tilting the transducer and not or rotating the transducer, not tilting it. It looks very similar, but it is what you see is you see different portions of the myocardium here. You see the lateral portion of the myocardium, and in this region you would be able to detect small infarcts in the lateral region or the extension of infarcts into that region that you would normally not see with the standard views.
If we look at the schematic that we saw before and now also include this atypical lateral view, we can see where this view is oriented. We have the true lateral wall very nicely visible here, and we also transect the aorta. This is the reason we have a view that looks very similar to a five-chamber view. We're transecting here, or we're cutting also through portions of the aorta. This is such an example and a comparison of the atypical lateral view and the five-chamber view. Those are not the same views. This is tilting the transducer upwards, and this is rotating the transducer so that we also see parts of the aorta here. The atypical lateral view is very good to look at wall motion abnormalities. Sometimes small infarcts in the lateral region are only visible in this view, at least to my experience. And it's also good to look at the LVOT for the assessment of obstruction and for atypical or especially eccentric aortic regurgitation jets. We've already talked about the short axis view, which is located at the very tip of the heart, when we talked about the short axis views from the peristernal window. And I mentioned that it is sometimes better to use an almost apical approach to look at these views. So I'll just, for review purposes, I'll talk about this view once more. This view looks like this, where you have a very apical position with only the last tip of the heart visible, with the chordal structures and the papillary muscle nicely visible. And it's good to look at apical thrombi, aneurysms, supraapical wall motion abnormalities, and to assess apical rotation. So this concludes the apical window. Let's turn to the next window, the subcostal window, which is also very important, which I believe should also be an important component of every echo exam.